everybody. Welcome to the weekly webinar relating to COVID-19. It's a great pleasure to have tonight Suzanne Joels, who I've known for a very long time as a daughter of a distinguished physician, and also as one of the young people in a Jewish community. And it's always a bit of a jolt when you find that these are the people that you knew at that stage are now running huge chunks of the health service and doing, from all accounts, remarkable jobs of it. Connecting this to subject to COVID-19 with the elderly and with the issues of mental health, not only directly related to disease, but in general. And we're absolutely delighted that she's found the time to actually contribute and prepare a session for us tonight. So, Suzanne.
Thank you very much, David, and thank you for inviting me. And more than that, thank you for describing me as a young person, which I don't think I've been described as for about 20 years. Anyway, what I was going to do tonight is talk to you about dementia in 2020, where we are now. And as David pointed out, I'm an old age psychiatrist and also clinical director for services for aging and perinatal mental health at Camden, Islington NHS Trust. So what I wanted to cover tonight was I wanted to talk about, initially on a positive note, the changes and the advances that we've seen in dementia care over the last 10 years. There was a very interesting, important paper that came out on prevention at the end of last month, which I also wanted to talk about. And finally, I wanted to talk about what's been happening to people suffering from dementia during the pandemic. So I thought I'd start off by just showing you this diagram. And what this diagram shows is it shows you the demographics of the population in 2009 and where we're predicted to be in 2033. The lighter shaded areas is the area that's predicted to be the growth in the population. And as you can see, the population overall is going to be growing quite significantly, but the greatest bulge is going to be in the older population. And there's not a significant growth in the younger population. And this is very important for a number of reasons, not least of all economic reasons, because the social care that we're able to provide to the older populations is of course generated by people in work. And the cynic in me would say this is the main reason why we've seen such an improvement or such a growth in dementia care and focus on dementia going back to 2009. So dementia, when we think about dementia, we probably think about it as being a problem of the developed world, but in fact, there are 18 million sufferers predicted to have dementia worldwide, and that is predicted to rise. The reality is the majority of sufferers, of people living with dementia, will be living in lower and middle income countries. And in the UK, we now think there's about 850 people living with dementia, and the majority of those will have a diagnosis of Alzheimer's disease. There's been some interesting epidemiological work that's been carried out over the last 30 years. And this has really led us to our understanding of what the predicted prevalence of people with dementia will be. And this is the Cfas study, which was led by Carol Brain in Cambridge and her group. And the Cfas study originally looked between 1990 and 1993 at over 7,500 people. And what they did was that they looked at lifestyle, health, socio-demographic factors, and went on to screen 20% of that population and went on to do a diagnostic assessment. And from that, using a computer algorithm, they managed to predict the prevalence rate of people with dementia. When they went back in 2008, what they found was a surprise. They found that there was a 20% drop in the numbers of people they had anticipated having a diagnosis of dementia. And it's thought that this is probably, so the drop was in the prevalence rates by age. So, and it's thought that the drop is probably due to the fact that people's lifestyles had changed, people's educational attainment had changed, that there was reduction in various different vascular risk factors. And we know that what is good for the brain, good for the heart, is also good for the brain. And that probably explains the reduction. And that was quite a major change. So this slide, what this graph shows is it shows the age prevalence of people with dementia in 1990 from the Cfas 1 study, and then again from the Cfas 2 study, which started in 2008. Overall, the numbers of people with dementia are rising, and that's because there are increasing numbers of older people. But at each age, the incidence of people with dementia was falling. Back in 2007, there was a recognition that people living with dementia were not being given a diagnosis, and NICE recommended that memory assessment services should be set up. And these would be a central single point of referral for all people with a possible or suspected diagnosis of dementia. And there was a recognition that the majority of these people will be living in the community, and therefore the suggestion being that these services would be provided by community mental health teams. So we set up our service in 2009, but most services were set up from 2010 onwards. And it was important because when we set up our service, there was a massive, variation across the country in terms of where services were and where there weren't. Now there are services in every single borough, but earlier, 10 years ago, there weren't. It was very much a postcode lottery. Probably one of the most important documents was published in 2009, and that was a document that was put together initially by the last Labour government, but the message was very much carried on by the coalition government. And the aim of the National Dementia Strategy was very simple. It was just that all people and their carers should live well with dementia. And there were a number of objectives that they looked at which would have that outcome. They looked at things like awareness and identification. They also looked at carers. They looked at how people with dementia were looked after in hospitals. They looked at improving people's support around end-of-life care. Importantly, they also looked at joint commissioning, so that services, health services and social care services were very much joined up, and it was the same group of people who were commissioning both services to create seamless services for people with dementia. And really importantly, they looked at increasing research into dementia, because at that stage, and still to a great degree, the amount of funding that went into dementia research was a minuscule proportion of that which went into other things such as cancer research. There were a number of other initiatives that followed on from that. So in 2013, the G8 Summit focused on dementia. David Cameron was a great supporter of dementia, and he produced his Prime Minister's Challenge in 2015, which had some objectives for what dementia care should look like in 2020, and had a very strong focus on increasing the number of people who were participating in dementia research. So the goal was that 10% of the population with dementia would be enrolled in a research trial or some sort of research. Unrealistic, of course, because that would mean over probably 85,000 people with dementia being enrolled in research trials, and actually then aren't the number of research trials going on to have that number of people participating. And the other important report was this report that was produced by Shubi Banerjee. And at that time, we knew that people with dementia were being often treated with antipsychotic medication, which has a number of side effects, causes sedation, which was often used as a way of managing people who had behaviours that challenged their carers or care home staff. And it was very easy to write a prescription, but it was very clear that people were being over-medicated, and as well as causing sedation in dementia, these medications can cause other problems such as increased risk of stroke and higher mortality. Other initiatives included the NHS collaborating with joint dementia research. And what joint dementia research is it's a single database, online database that anybody can log into and sign up to if they're interested in participating in trials, whether or not you have a diagnosis of dementia. And the idea being it was a central database that trials could recruit study participants from. The third sector have been incredibly important in terms of providing services, and the two main organisations that provide services for people with dementia, and fantastic services for people with dementia, are the Alzheimer's Society and Age UK. And then there was the aspiration to look further afield. So the National Dementia Action Alliance was one way in which education and trying to reduce stigma could take place. And the idea behind the National Dementia Action Alliance is to improve the experience of people with dementia in local communities. So to create dementia-friendly communities, and would be the participants in the National Dementia Alliance with people such as banks, libraries, local businesses. What about treatments? Well, we've unfortunately, very disappointingly, drug treatments we thought would be developed by now, but the trials have been disappointing. We haven't as yet developed any disease-modifying drugs. So the next slide just shows you, this slide is quite out of date now, it's back from 2010, but actually what the slide shows is it shows the number of different trials that failed at different phases in terms of their development. So it's a plethora of different drugs that have been developed, all of which have failed, and they've all acted on slightly different systems. And the only drugs that have been successful are these ones in the middle, which are donepezil, rivastigmine, galantamine, and memantine, which have been around for about 20 years and are what we call symptomatic drugs, not disease modifying, so they don't affect the underlying disease process. We've been much better in terms of developing psychosocial interventions. We understand the importance of having a person-centered approach, how important people's life story is in terms of developing their care plans. We know that structure is very important, and there's been some work looking at non-pharmacological interventions. So cognitive stimulation therapy, for example, has been developed, which has been shown to be beneficial for people with dementia. We also know that people with dementia are less likely to have their physical health adequately treated. And certainly women with dementia are less likely to have attended a GP in the last year. So it's really important that these things are considered. People with dementia are less reliable at taking medication, and often it's an area that gets neglected. And then there's all of the interventions that have been developed for carers. One particular intervention, the START, which is Strategies for Relatives intervention, which was developed by Professor Livingston at UCL, has been shown, it's a manualized intervention, which is delivered over 8 sessions on a one-to-one basis. And that intervention has been shown to reduce anxiety and depression for up to 6 years. So that's a significant improvement and impact in terms of quality of life and also an economic effect. So I want to move on to prevention. And I'm afraid it's the same old story with prevention. This is an old Andy Capp cartoon. In August, there was this this report which was produced by the Lancet Commission, which looked at prevention and was cited in quite a number of newspapers, so you may have seen something about it. What they did was the original Lancet Commission looking at prevention or modifiable risk factors for people with dementia first reported in 2017. And the commission is made up of a group of leading academics. And what they've done is they've looked at systematic reviews and also meta-analysis, and also good quality individual studies. And where there hadn't been the meta-analysis or reviews in place, they've gone away and done them. And they've identified 12 modifiable risk factors. And if these risk factors were modified, it could account for or reduce the amount of all dementia by 40%. The change between the 2020 report and the 2017 report was that they identified 3 additional risk factors. So I hope you can all see this. Essentially, they produced this diagram which actually demonstrates beautifully the different risk factors and the importance of these different risk factors at different times in an individual's life. So at an early age, what we know is that education is very important. So people who have been educated to tertiary level have got a reduced risk of developing dementia. But that risk, modifiable risk, is actually quite high at 7%. Then in midlife, there are a number of different factors, and hearing loss is a really important modifiable risk factor because it's fairly easy to modify this risk. So all of those people who are nagging their spouses to put their hearing aids in, it's really important. Because it will reduce your risk of developing dementia. The other modifiable risk factors, hypertension and obesity, we understand a little bit about the vascular relationship with that, but also other things that are interesting that have come to light more recently. So about a year ago, there was quite a lot of stuff in the press about the higher incidence of Alzheimer's disease in footballers who head the ball, and whether heading the ball is actually a risk factor for developing dementia. And I think the evidence base suggests that actually it is. Alcohol as well. So I think most people realise that actually if you drink huge quantities of alcohol, you are likely to cause brain damage. What the Commission showed was that the level of alcohol that actually was identified as a risk was 21 units per week. So that is 2 large glasses of wine a night. And I think there'll be a number of people who'd be quite shocked by that amount. Smoking, we understand. Social isolation, physical inactivity, we all understand. There's a very strong link as well between diabetes and going on to develop dementia, and also depression. Depression is a risk for going on to developing dementia, so it's really important if people are depressed that that is adequately treated. It's not a normal state of aging, being depressed, despite what some people think. And air pollution was shown up in 2020 to also to be a modifiable risk. So if you could eliminate all of those risks or address all of those risks, you would be able to potentially modify 40% of all cases of dementia. So I wanted really just to give you a brief background of where we are now. And then I wanted to talk about the impact of COVID on dementia. So I know most of the series is focused very much on COVID, but I wanted to give you a background that actually, I suppose the message I wanted to give you was that we had come so far in terms of dementia care over the last 10 years. And services have been set up, robust services, which really have an impact in improving people's quality of life. And I want you to keep that in your mind so that when we go through these slides, you'll understand exactly how devastating the impact of COVID has been. So this photograph, or this picture, was a picture that was taken at the beginning of lockdown when there was a lot of panic buying around. And I think it was commented on as a sort of state of where we were at in our society. The elderly gentleman who's come out to shop and the shelves have been absolutely stripped bare. What I want to talk about is the mortality and morbidity that has happened specifically just due to the disease. I wanted to talk about the impact of lockdown, the impact on carers, and then to finish off with the care home story, which has been one episode which we are probably not very proud of. So this again, all very topical. This was last week's headline in The Guardian, which said that a quarter of COVID victims in England and Wales have dementia. And this this came about from a study. So what's been happening with COVID is that a group of academics, I think the work is hosted at LSE, but they have been tracking what's been happening internationally for people with dementia and COVID. We know that COVID is an illness which older adults, and the older you are, the poorer your outcome is. And this is certainly the death rates are much higher amongst people over 65, and higher still the older you get. So 86% of all COVID-related deaths have been reported amongst people over 65. And you might think that this is understandable. So these people are more likely to have comorbidities, other things which we know are also associated with poor outcomes in COVID. But also we know that if you have a diagnosis of dementia, you are at higher risk of dying from your COVID illness. And so this is where the headline comes from, that 25.6% of all COVID-related deaths in the UK were people living with dementia. That's far, far higher than the prevalence of people with dementia. And it's not just in the UK. This is a finding that has been replicated across Europe. So quite early on, obviously Italy had their first wave much earlier than we did. And they showed that the mortality rate was 62% of those people who had a diagnosis of dementia. And that compared with just 26.2% in those people without dementia as well. Mm-hmm. But as I said, regardless of your age, you will have a poorer outcome if you also have a diagnosis of dementia. What is this all about? Well, we don't really understand it. It's one of the interesting things is there is an allele called ApoE, and if you are homozygous for this allele, if you have these two E4 alleles expressed, you will have a higher incidence of not only vascular disease, but more importantly of dementia. And so your risk of dementia is, I think it's about 17-fold higher if you're homozygous for the E4. And we also know what is interesting is that when they studied people with this homozygous expression, they found that they had a higher risk of severe COVID infection. And this was independent of whether they had any of the other illnesses. So whether they had diabetes, cardiovascular disease, and more importantly, whether they had dementia. So it's a story that's unraveling, that we don't really understand all of the explanations. What we do know, however, is that and I think those of you who saw Laurie Wiseman's webinar will remember him talking about delirium and about describing this delirium in ITU, but also which carried on for several weeks after his acute phase of the illness. And my colleagues, my liaison colleagues who are working in the acute hospitals have all described this phenomenon of delirium in COVID. And we know that in dementia, people are less likely to present with the typical symptoms of fever, cough, anosmia. They are much more likely to present with this delirium, which is slightly unusual and in its presentation. So we had, during COVID, we converted a wing of one of our wards, one of our older adult wards, for people who tested positive for COVID. And when we eventually were able to test the entire ward, we did find some asymptomatic patients, but also those patients with symptoms also didn't have classical symptoms. So, and there's also this other issue about people with dementia. We don't know how many unavoidable deaths there were due to lack of access to appropriate care and treatment. There were a lot of staffing shortages, and we don't know the impact that that had on people with dementia as well in terms of a number of deaths. I think everybody's found lockdown difficult, and certainly I think various different groups of the population have found it much harder. So I think young people, we know that there's more mental health issues with people in their under 25, which we're now seeing, but also older adults have not done well during lockdown. And for people with dementia, it's been really important, because I mentioned earlier on about how important it is in somebody's care plan to have structure, to have regular stimulating activities. And of course, these have all stopped during COVID. Also, it's important for people with dementia to have regular contact with their family and friends. And again, this is something that's not been happening during COVID. We know that this has had a specific detrimental effect. So in Camden Memory Service, for example, we've had a lot more people who have contacted us because their relatives have become more agitated, their rate of dementia has increased quite rapidly. And it's a story that we hear over and over again for people living with dementia. And a study done in Spain did demonstrate this, that actually people with dementia displayed far more symptoms of distress, agitation, wandering behaviour after 5 weeks in lockdown than they had done in 5 weeks previously. And this doesn't obviously have an impact just on the people with dementia, but for carers, respite is terribly important. Knowing that you can rely on somebody coming in, taking over from you for a couple of hours, has been vitally important. And we know that there's been an enormous impact in terms of stress and exhaustion on carers. I think the other thing that we hear from carers is that carers have found it quite difficult to understand, to marry up the national government guidance with actually what is best care for somebody with dementia. And a lot of decisions when you're looking after somebody with dementia are very much a risk-benefit analysis. So keeping somebody with dementia cooped up, not allowing them access to family, may actually be a far greater risk than the risk of exposure to potential COVID. What we found, so in Camden and Islington, we're very fortunate in that we've been commissioned to provide a memory service that looks after people from the moment of diagnosis until for the rest of their journey with dementia. And people are generally followed up. They get a phone call or a visit once every 6 months just to check in, see how they're getting on, seeing if there's anything that they need to be signposted to, anything that will improve their quality of life or any difficulties they're having. So we immediately had lists of 90% of the people living in Camden, Islington, who had a diagnosis of dementia. And we were very quickly able to identify those people who were at higher risk and most vulnerable. So we were able to stratify the population very quickly and put in place a monitoring plan for them. So if somebody lived on their own, didn't have a reliable care package, we would phone them once a week just to see how they were getting on, making sure that they had access to all of the voluntary organisations that were delivering food packages, making sure their shopping was done. That wasn't possible in most of London. So in most of London, people were relying on their GPs knowing who they were. There weren't those databases that existed, and therefore it wasn't always easy to find people who were vulnerable. And as a result, I think there were lots of stories of people whose maybe their carer hadn't been able to visit, who had been missing visits, missing medication, missing meals. There was no way initially of keeping a track on that. Later, and the other thing about people with dementia was that when the government initially published their lists of who was vulnerable, who should receive the regular food packages and the shopping, dementia was not one of those conditions that was listed. And therefore, it was only later on when GPs were encouraged to add people who were vulnerable to those vulnerable lists that was recognised. again, one of the issues with lockdown was people being able to access treatment interventions. And I think for lots of people, they were very worried about going out, about going to their regular appointments, about allowing carers, allowing professional staff to come in. And therefore, that also has had a fairly negative impact, not just on people with dementia, but also their carers as well. And I think everybody, I think it would be fair to say, has been confused at some stage in terms of, are we staying alert? Are we staying home? Are we washing our hands? How do we wash our hands? When do we wash our hands? Are we wearing masks? Are we not wearing masks? Just imagine how confusing that is for somebody with dementia, and imagine how difficult it is to implement for a carer of somebody living with dementia. So it's been very difficult for people with dementia to keep themselves safe. And as we have come out of lockdown, or as services have developed within lockdown and later came out of lockdown, many different services and support services have been moved online. We know that older adults, and particularly people with dementia, often suffer digital exclusion, and that's causing more health inequalities for this population. So I've touched briefly on what's happened to family caregivers, and there has been some quite difficult, people have been making very difficult choices. People have been trying to decide between making the difference between whether their loved one gets regular care or whether in fact they take on the care themselves because of the risk of infection. So in Ireland, in Northern Ireland, they carried out a survey of, I think it was about 100 families who had somebody. They weren't just people with dementia. There were people who had somebody within that family who were receiving a care package. And an astonishing 14% of all families were cancelling their care packages. Now, these were people who had been identified and classified as being at the very highest need, which was the reason they were receiving their care packages. So family members were either taking on the care or the level of care was suboptimal. The Alzheimer's Society, and one of the offerings that they do is they have a very good online forum, which is called Talking Point. And they had reported a 6-fold increase in the number of people who were joining that community. And that tells you something about the desperation of people, the desire of people to try and find other people that they are in similar positions, to get support wherever they could find it. And a survey by the Alzheimer's Society in Ireland did a survey with 95 carers of people with dementia, and the things that they identified, some of these things are very easy to fix. So the concept of not being able to shop, that was something which was really very easily remedied. The loneliness and the isolation, a lot of support services have used telephone calls to help people stay in touch. People have been incredibly creative in terms of thinking about book clubs online. University of the Third Age has moved its offering online. There are amazing resources, reminiscence resources, all sorts of different resources that people could access. So a lot of these things could actually be fixed, but yet there's also that sense of feeling on your own, not only worrying about the person you're looking after, but also worrying about your own health. If you become ill, what's going to happen to them? All these things were real sources of anxiety. So that's what's happening in the community. And I wanted to move on to talk about what's happening in the care homes, because I'm sure everybody's read something about the difficult situation that's been happening in the care homes. And I think it was when COVID started, our trust reorganised or organised what they call the command structure, and I was one of the clinicians who was involved in that. And one of the tasks that we had to do was to read all of the information that was coming down from the Department of Health every day and try and assimilate that and try and understand what the implications were for our services. And I remember right at the beginning, there was a real push around the anxiety around running out of ITU beds, the anxiety of seeing scenes such as those scenes that were seen in Italy, where people were being treated in corridors. It was a really anxiety-provoking scenario. And I think there was a sense that actually if people are discharged from hospital into care homes, they will be safe and they will be cared for. And so I think we were in a way quite negligent in terms of our practice, in terms of thinking about discharging people from hospital who may have been carrying illness. And this graph is from the Office for National Statistics, and what this graph shows is it shows the number of deaths involving COVID-19 in the care sector, and the blue bars are the deaths directly attributable to COVID-19. The yellow, brown, orange, however it's come out in your computer, bars show the all other deaths, excluding COVID-19, and the black line at the bottom is the deaths in 2019. And what this shows is, I think the first thing to say is that the number of deaths involving COVID is enormous as a percentage of deaths. The other thing, however, it shows is that there are an excess number of deaths of people not from COVID as well. So that period, there was a huge attrition rate in care homes. A huge number of people died in care homes. So when we look at who died in a care home, those people who died in a care home who had a diagnosis of COVID, 75% of those deaths were in people with dementia. But when we actually managed to start rolling out testing in care homes, what we found was actually 43% of people who tested positive for COVID were actually asymptomatic. Another 18% had atypical symptoms. So you can imagine the scenario. You had all these people wandering around the care homes who were thought to be well because they didn't have any symptoms, and they were infecting other care home residents. So I think this was one of the difficulties early on. Your outcome if you were in a care home and you then developed COVID was very poor, so half of those people died. And it wasn't just the care home residents who were contracting COVID and becoming sick. And what we discovered was that certainly the rates were higher in largest care homes, and the reason for that was they were more likely to bring in agency staff who would be doing a shift in one care home, moving on to do a shift in another care home and transmitting the virus from care home to care home. There was also a shortage of PPE at the start of the pandemic, and that definitely contributed to an increase in the infection rate. And these carers who were contracting COVID as well were very often from BAME backgrounds, and we know that they had poor outcomes as well. So in Islington, for example, they had a care home who, at one stage, they had lost 11 residents, but they'd also lost 3 members of staff. So you can imagine the sense of anxiety that provokes in the homes. And, you know, care home staff are used to death, they're used to their residents dying, but not in the numbers that died during COVID. But what was really impressive was that many care homes were very quick to adapt. They put in place policies. They really, the level of care from the staff was quite incredible. They really, you know, I think it's fair to say that the majority of staff working in care homes really sacrificed a lot of, you know, their family life to make sure they kept their residents safe. Some of them moved into the care homes. It was really a difficult situation. It wasn't just a difficult situation in the UK. In fact, the UK probably did better than other areas. And there were some terrible reports in the news about what was happening internationally. So in Madrid, they found 23 people were found dead, including 2 nuns who were providing the care. And the same was seen in Alicante and also in France. And what was shocking about the report in France was that those 24 deaths out of 140 residents were found to be due to very basic care not being able to be provided, because at a 40% absenteeism rate, there weren't enough staff around who were able to make sure people were drinking on a regular basis, making sure, attending to people's basic needs. And I think all of us who were providing 24-hour care facilities, be it in a hospital setting or in a care home, the difficulty with staff absenteeism due to sickness was a real problem, trying to keep people safe within those settings. Now, right at the start, you remember I talked about time for action. I talked about the emphasis on trying to reduce antipsychotics for people with dementia. And you may remember that I said that the target was under 10%, and you can see that we'd actually achieved that. What had happened with COVID is that we've seen a rise. It's a small but significant rise in prescribing of antipsychotics. And as you can imagine, this is because all of the other types of interventions that we can offer are no longer available. People weren't able to go into the care homes. Structure and routine wasn't able to be delivered. And the other thing that happened at the start of COVID, as I talked about the anxiety about discharging people from hospital as quickly as possible. Also, there was a sense that actually we shouldn't be admitting people from care homes either. So many people from care homes were told to stay in their care homes. They'd be looked after in primary care rather than coming into hospital when they became unwell. And there was an outcry because it was felt that people were being given do not attempt resuscitation orders without proper consideration, and reports again of people being phoned up by their GPs who'd been asked to make sure people had advanced care plans in place, and people not really understanding what was being asked of them, but just getting the message that the GP wanted them to sign a DNAR. I don't think that was the case, but I think the confusion that happened as a result of these things being done on the phone was significant. And memory services were not considered essential services, so most memory services closed, and certainly if they were closed to assessments, we had to redeploy quite a lot of our staff to staff the inpatient units. So that was another area where people weren't able to access service. And bringing people in to have a scan as part of their diagnostic workup has been challenging. Obviously, fewer scans are being done because machines have to be disinfected between patients, and it's still a problem. There's a much longer wait now for scans. So at the beginning of the pandemic, one of the things that happened was that there was government guidance published banning all visitors to hospitals. Obviously, this had quite disastrous effects on people with dementia. And I think the guidance has changed now, so that people with dementia are encouraged to have a family member come and visit them. That's one of the reasons why people can come in, but it's not universal. It's up to the trust themselves to make that decision, and so that currently is being challenged by a charity. In terms of basic human rights, has been taken to the courts. And as I said, by the ruling was changed, but it is down to individual trusts. So in summary, I think it's fair to say that dementia patients have been the forgotten victims of COVID-19. A lot of those services that were stood down are still not up and running. So we've now gone 6 months without services being able to be provided in the way that they were. That's a long time in the life of somebody living with dementia. We know that there's been a disproportionate number of deaths in people with dementia, and that we failed, I would say we failed to protect our most vulnerable individuals. And we need to try and think of ways in which we can get our services up and running again. So some of the local authority day centres, for example, are setting up and started running again, but with much reduced numbers of people, which means that people can't access them to the degree they had before. And that we know about the numbers of deaths due to COVID, but we also know that there have been a large number of deaths that have been due to people not being able to access interventions. And the toil on families, carers is enormous. And as we've seen over the weekend that the numbers of cases have increased, I think we all need to think about what's going to happen in the second wave. So I don't like to leave on a negative note, but I think the thing to focus on is the fact that actually we do have great dementia services in this country, and hopefully we will get back to being able to deliver them in a way that we were prior to February again. Thank you.
Let me unmute myself and say thank you very much for a tour de force of going through both the background and then the foreground of what's happened with COVID-19. There are a couple of questions that come through and that we've had. One of these questions, if I can start off with them, it was just in your background on the research side. You said there were 85. You'd need 85,000 patients to fill in all the trials. One of the questions about that is that there's another piece of information that we're often given, which is that there aren't enough aged people in trials that look in general. Is that still a problem, that there are not enough aged people included in trials of medications going through in general?
So I think there are reasons for that. So I think so the point I was making was that if we had 10% of everybody living with dementia involved in a trial, that would be 85,000 people. And there's not that number of spaces in trials for people to participate. I think the reason we know that any medication we've developed has not been tested or trialed on older adults. And I think there are generally there's good rationale for that. I think it's difficult. I think, ultimately you do want to roll medications out amongst the elderly population, and it depends what the trial is for. So, and also to point out that a large number of trials in dementia do not involve medication. In fact, the majority probably do not involve medication. But I think it also depends on what you're actually developing medication for. So, if you're developing a medication for dementia, then obviously you need to include older adults. If you're developing medication for a condition that is very common amongst all ages, you probably want to trial it in people who are most robust, who are at least at risk of developing complications.
Right. In your list of complications, diabetes was included in the late age group.
Yeah.
Is that I was a bit surprised to see that, because
yes. So I think we know diabetes is a risk for developing dementia, and certainly I think this is what they saw as most modifiable risk factors. So I think that the diabetes in midlife is obviously important as well, but you could actually impact more on people who develop diabetes in late life. So by thinking about, by checking people for diabetes, by thinking about prevention, so you reduce the amount of diabetes in late life. It's I think more about the degree or the number of people who are diagnosed with it.
One of the questions that's come up from John Newman is the question of the fact that dementia is often said to be the diagnosis made by children about that age. Is that a correct interpretation?
I think I'd be out of a job then. Um, no, it's not. I mean, a collateral history is very important when making a diagnosis. I think there is the sense of, so I quite often see people, and when I ask them about their memory, they say, well, you know, it's just old age. In fact, the reality is that memory loss is not normal in old age. What happens as we get older is we have our capacity to assimilate new memories is impaired because of the number of memories or number of neural connections that we have, and therefore it may be more difficult to learn new information. But actually, our memory is not impaired. So it's not right to say that everybody loses their memory as they get older.
Related to that, is deafness really a specific issue, or is that part of a kind of general neurological deficit?
It's quite an interesting area of research, and it's there's a number of different theories around it. I wouldn't want to talk in great detail about different theories because my knowledge base on them is not detailed enough. But it is felt to be, an independent risk factor for dementia, as well as the isolation that it causes. So, we know isolation is a risk factor, but there seems to be something around deafness that increases your risk of dementia in a way that other sensory deprivations, such as blindness, doesn't do.
Right. And one of the questions on the famous graph, and this one is one that I'm always asked so I can get my own back, on the famous graph of the deaths, the ones that are not due to, so-called not due to COVID-19, are those not due to COVID-19, or are they ones where they are 30% of COVID-19 tests are negative, are false negatives? So does the false negativity account for those non-COVID-19 so-called deaths?
Well, I think if we see what happened in Italy, in France, where because residential homes were short-staffed, there weren't enough staff to make sure people were adequately hydrated. It could be that people, you're staffing your home with people who don't know the patients that well because you've had to bring in additional staff, and therefore they're not picking up changes in presentation, and which may be, an indicator of underlying ill health. And we know that it's really important, and that older people, particularly older people with dementia, are less likely to present in a typical way with other issues. So I think we do know that there are some false negatives, but I don't think that explains the whole situation.
Right, and the other question, the follow-up question that one gets asked is, weren't these the people who were going to die anyway in the next 6 months? So have we just accelerated that process?
I think, my answer to that is always, I don't think that makes them less significant. So in a way, if you remember, the graph then goes and falls under the numbers of deaths that were expected compared to the previous year. So yes, some of these people would have died anyway, but that doesn't make them any less significant. So, I think yes, you're right, that is quoted, but
it looks as though it's a very significant figure, but you keep on getting back onto it. And there was the question about the nature of the care, the nature of the care and the nature of the carers. I mean, are there changes that you have to introduce in your general pattern of care that's a consequence of this, particularly for the second wave, but in general?
So I think what we the sort of buzzword amongst the NHS has been recovery, so trying to recover services, but that word has sort of changed a little bit over the last week or two, which is all about preparing for the second wave, which I think all trusts are doing now. I think in terms of what we do with people who are inpatients under our care, I think it's just about streamlining. I think we actually got it right. You know, we didn't lose a single one of our patients on our older adult wards, which wasn't the same story elsewhere. But we had very good support from the Whittington Hospital because our inpatient unit is right next door to them. And we had incredibly committed staff. I think there are certain things which will be done very differently, and testing is definitely the most important thing. In terms of in the community, it's about thinking about the risks of people. So up until now, what we've been doing is we are carrying out assessments. We are going into people's homes and we're doing assessments in people's homes. We are wearing PPE, so we're going in wearing masks. We are looking at providing more carer support remotely. So whereas we invited people in, we now will speak to them over the telephone, use video calls with them. But it's very different. I mean, one of the things that's changed enormously has been the way that the health service, community services work. So we have to comply with social distancing when we're at work. And that's had a major impact because we can only have 40% of the staff in on any one day. People are having to work from home. And so you lose an awful lot in terms of those corridor conversations about patients, you know, in terms of team building, you know, new staff joining teams. It's very, very different for everybody providing care. And it's not just how do you provide care for patients, but also how do you make sure that the care that you're providing is joined up, seamless, that people have those opportunities to sort of spark ideas of off each other and be creative.
So that you can only have 40% of your staff on any one day.
Yeah.
So that's you way below normal staffing levels.
Sorry, this isn't on the inpatient unit. This is people working in community settings. So people in offices rather than people actually working on the wards.
How do you, it's not really, I suppose it's a borderline question for you, but how is the change in general practice to online working going to impact on dementia care, do you think?
I think my big anxiety is whether people will be recognised and referred. And I think, I mean, our referral rate is down slightly. We are still getting referrals, but I think referral rate is down. If people aren't seeing their relatives, they're not picking that up. So I think that has been an issue. My friends who are working in general practice say they're much quieter than they used to be. So that's clearly we're going to be missing some cases of dementia. And what NHS England have done is that they track the dementia diagnostic rates across the whole country, and there has been a significant drop. Now that may be partially explained by the number of deaths that we've had. It's also partially explained by the fact that memory clinics have been closed for assessment. But what we would hope to see that start reversing, because it's, even though our services are not what they were, it's really important people are identified early with dementia.
I think that we're going to release you in a minute or two, but in proposing to say thank you for really a wonderful webinar and a wonderful description of the situation. The thought takes me back to Marcel Levy's talk, in which he headlined it that it was, professional leadership was a key issue. And I think that that's one of the things that shone through this, that there's been professional leadership that has been really quite remarkable. If you say that how you've maintained the service in London, and it gives one a little bit more confidence in what's going to happen in the second wave, which I think we all agree is going to happen. So thank you very much indeed.
Pleasure. Thank you. Thank you, David.